Let's get started with today's clinical topic. Our speaker today is Dr. Thomas Jackson. He's the founder of the Chicago Center for Cosmetic and Implant Dentistry, and he lectures internationally about the periodontium and its relation to the cosmetics of teeth and implants. He's graduated from Northwestern University Dental School, which unfortunately isn't around anymore, and he did a 2-year GPR at Johns Hopkins. He then continued his training in the combined 4-year perio and perio-pros residency at the University of Pennsylvania. His topic today is one that we've had a bunch of requests for: the maintenance of the full arch prosthesis. So I am delighted to turn this over to Dr. Tom Jackson. Tom, you can go ahead and put your screen up.
Okay. Let me get it here.
Yeah, we're just seeing your Zoom login at the moment window. There we go.
There you go.
Okay.
We're
Can
there.
you
It's all good.
You got it.
So let me just do that. All right. Well, thank you, Dr. Park. I want to thank you for the invitation to be able to present to your group. We've had several conversations in the past, and it gives me great pleasure to be able to do that. I also want to thank Andy. Andy's been very instrumental in coordinating this, answering my questions, and getting everything so that I feel very comfortable with the presentation. I'd like to thank the group, everybody that's out there that's taking time out of their schedule to be able to join me as I present one of my favorite topics, and that's on the maintenance of the full arch restoration. I just want to disclose that I do have a financial interest in the company, the AutoFlosser LLC. So as we begin, I want to set up just some learning objectives. I think it's important to be able to come back to practice, come back to life with a few little nuggets, as we've already heard this morning. Just makes us better people, better practitioners. I want everybody to understand that there's different types of full arch implant restorations. They're not all created equal. And then there's different factors that affect their maintenance over time. Be able to recognize the clinical signs and etiology of peri-implant mucositis and peri-implantitis. It is beyond the scope of this presentation to talk about treatment, but it's important to be able to recognize it when they occur. Describe the prosthetic seam and how it affects maintenance over time. I think everybody needs to be able to develop a protocol in their office on how to treat these full arch restorations at maintenance visits. And then lastly, become familiar and know current at-home oral hygiene aids and tools available for our patients to perform plaque removal. So to begin, this is a patient of mine that presented to me years ago. He was 80 years old, and his chief complaint was that he wanted to be able to eat nuts. His current removable prosthetic had failed, and I had treatment planned him for an upper and lower full arch implant restoration following an all-on-4 protocol. After several months and several surgeries and 8 dental implants, I was able to provide him an acrylic over metal all-on-4 full arch implant restoration. And then on the date of delivery, the question becomes, now what? You've just provided this fantastic restoration to your patients. The question is, how long is it going to last? And maybe more specifically, what's going to cause it to fail? What are your patient's expectations for the future? And then what can you and your patient do to prepare for it? So what we're really talking about here is maintenance. And maintenance is defined by Webster as the ability to keep in an existing state and to preserve from failure or decline. And so when we talk about the maintenance in dentistry, everything has its own level of maintenance. A posterior 3-tooth bridge has a different amount of maintenance than an anterior class 2 composite. So in this presentation, we're going to be talking about the maintenance of the full arch implant restoration. But we need to know that there's different types of full arch implant restorations. In 1989, Mish, to be able to help define these different types, created different categories. Let's look at them. He called or categorized the first group as an FP1. It's a fixed prosthetic restoration where the prosthesis replaces only the crown of the tooth. It looks like a natural tooth emerging from the gum line. He then categorized a second subset as an FP2, again, a fixed prosthesis replacing the crown and a portion of the root. In essence, this type of restoration would look like it has gingival recession. And then lastly, the FP3 category, subcategory, a fixed prosthesis that not only replaces missing crowns, but the gingival color and portion of the edentulous site as well. Today, most implant restorative dentists don't intentionally provide an FP2 restoration. We don't intentionally want to give the aesthetics of generalized recession. So for the most part, most of our full arch implant restorations are FP1s or FP3s. As an example, this is an FP1 restoration. It has its roots in crown and bridge dentistry. Much of the procedures and many of the techniques are the same. The prosthetic materials that are used, ceramic metal and zirconia, and these can be either cement or screw retained. On the contrary, an FP3 restoration has its roots in removable dentistry, using removable teeth and processing techniques. The prosthetic materials that are used in this type of restoration can be acrylic with a metal frame, ceramic metal, and zirconia. These are mostly screw retained restorations, and they're screw retained because it would be very difficult for a provider, a practitioner, to clean cement out of this type of restoration underneath the prosthetic. If we're talking about full arch restorations, I think that no presentation would be complete without looking at the history of the full arch restoration. So briefly, the Swedish group published in 1981, the very first paper on the modern day endosseous dental implant. And what's interesting is that they used a full arch implant restoration on top of those dental implants. The fabrication at the time was using a gold frame with acrylic facings. These bridges were all facultatively removable, which means that they were screw retained. And they did not include a prosthetic substitute for resorption of the alveolar process. These were FP2 restorations. Interestingly, in the paper, they had commented about the aesthetics of these, and in certain patients, the aesthetics was not great. To confirm the results of this study, the Toronto group, headed by Zarb, wanted to confirm the repeatability of the success of dental implants. And so they tested dental implants again in a full arch restoration. In this case, their prosthetics were slightly different. They used artificial teeth, denture teeth, and a soft tissue analog, which was processed on the framework. This is 1990, but this looks very similar to what we're doing today in the FP3 full arch restoration. These two were removable, screw retained. And interestingly, the authors had commented that the result of this type of restoration compromised the access for maintenance of circum-implant tissue health. 1990, aware of the maintenance problems with these types of restorations. There's been a surge in the popularity of these restorations, and there's other names for them. We call them all on 4, or maybe all on X, because we're doing more than 4 implants these days, fixed detachable, or hybrid, screw retained hybrid dentures. They go by all these names. But they're quite popular in the community. We don't have to look any further than Glidewell's own website, where they've fabricated over 2 million of these restorations. In my community and communities all over the country, Clear Choice has set up centers to treat mainly this type of restoration. In Chicago, where I'm located, a quick Google search for All on 4 results in pages of private and corporate centers that advertise this FP3 restoration. And lastly, there are patient support groups on Facebook that are dedicated to this type of restoration, where patients or future patients can comment on their own experiences with the procedure. So I feel that this type of restoration is so important and so popular that I'm going to really focus in on the maintenance of this type of restoration as we move forward in the presentation. One other interesting finding was the trend in material of this FP3 restoration. And again, looking at Glidewell's own data, there's been a trend towards more zirconia, or the Breakage prosthesis, than acrylic today. And we'll see how that comes into play shortly. So as we get into the maintenance of the FP3 full arch implant restoration, maintenance can be really categorized as either corrective or preventive. Corrective maintenance is reactive. This is something that we have to do after a problem has occurred. And we can subcategorize corrective maintenance into technical problems, biologic problems, and aesthetic problems. And this is important because if we know what's going to potentially fail, then there may be a chance to prevent it in the way that we provide treatment. Then there comes preventive maintenance, and this is proactive in nature, and it takes place before and aims to prevent the occurrence of problems. So as we get into the details of corrective maintenance, we're going to look at some of the things that occur most often with these types of restorations, and we don't have to look very far in the literature. There are many studies, long-term studies, that have commented on the corrective maintenance or the complications of this type of restoration. The most common technical problem, the most common technical maintenance problem of the FP3 restoration is breakage. Whether it's a tooth breaking off or the veneering material or the framework itself, this is the #1 problem that we're going to see with our patients. And there's a difference between acrylic and zirconia. 10 to 50% of acrylic and metal FP3 restorations are going to fail. 50% are going to fail. Something's going to break. Zirconia, whether it's monolithic or it's veneered zirconia, anywhere from 0 to 18%. But it's the most common technical maintenance problem that occurs. The next most common problem that occurs with these types of restorations is wear. At 5 years, 50% of our acrylic FP3 restorations are going to show signs of wear. Zirconia, 0%. And then down the list are other technical problems that occur: screw loosening, screw fracture, abutment fracture, implant fracture. Fortunately, pretty rare, but they do occur. But due to the scope of this presentation, we're going to look specifically at breakage and wear of these restorations over time. Next comes biologic problems that occur. Peri-implant mucositis on these FP3 restorations occurs 5 to 30% of the time. Peri-implantitis, 5 to 25% of the time. And then fortunately, fairly rare, implant loss, less than 3% of the time. And again, due to the scope of this lecture, and we're really just going to concentrate on some of these items that occur most frequently. So as long as we're talking about biologic complications and biologic maintenance, let's define what peri-implant mucositis is and peri-implantitis. In 2017, the World Workshop on the classification of periodontal and peri-implant diseases and conditions has defined peri-implant mucositis as an inflammatory lesion of the soft tissue surrounding our implants, specifically without the loss of supporting bone. This would be equivalent to gingivitis around teeth. The authors of this workshop have defined this as being biofilm mediated, plaque mediated problem. And it is the precursor to peri-implantitis. Peri-implantitis, again, is a pathologic condition defined by inflammation in the surrounding soft tissues with progressive loss of supporting bone. This is more synonymous with periodontitis on teeth. The authors mention that there is a strong evidence linking peri-implantitis to a history of chronic periodontitis, poor plaque control skills, and no regular maintenance. Here we go again with maintenance. In addition, there's some evidence linking submucosal cement, lack of keratinized mucosa, and positioning of implants making oral hygiene and maintenance difficult. Maintenance is important. The third subcategory of corrective maintenance, we've looked at technical problems, we've looked at biologic problems, and the last of the triad is aesthetic problems, aesthetic maintenance. Now with implant dentistry, especially FP1 type restorations, most of the aesthetic problems that occur with time, we're not talking about the aesthetic problems that are potentially relevant on the date of insertion of the appliance, but the problems that occur over time seem to be mostly related to tissue aesthetics, recession of the tissue around the implants, color of the tissue, inflammation of the tissue. Well, as described earlier, the FP3 restorations have prosthetic tissue built into the restoration. So we see relatively few aesthetic maintenance problems over time with the FP3 restoration, but they do occur. And when they do occur, they seem to be related more to the acrylic FP3 than to zirconia. We can see staining at the material interface between the teeth and the prosthetic tissue. And we can see wear and attrition of the teeth over time, which ultimately creates potentially an aesthetic problem. So what do we do with all of this information? Well, if we know potentially what's going to happen to these restorations most often, then there's the opportunity as providers to make decisions in the course of treatment to minimize those problems. So in this presentation, let's look at what happens most. What happens most, technically, is breakage, wear, and staining, and biologically, peri-implant mucositis and peri-implantitis. So if we're going to try to minimize corrective maintenance over time, let's minimize breakage, wear, and staining. So how can we do that? Well, first and foremost, when these prosthetics are being planned, we need to plan implant distribution. And by that, I mean, we need to minimize cantilever length. If we're replacing 12 teeth with 4 dental implants, inevitably there's going to be a cantilever. And Drago in 2018 had summarized the complications of cantilever length based on a ratio and concluded that if we can, as providers, minimize the ratio less than 1 of cantilever length to AP spread length, the complication rate drops to below 1%. So to minimize breakage, wear, and staining over time, let's get the implants in the right position to minimize cantilever length. Next, prosthetic material, acrylic versus Bruxer. We had already gone through the studies, and we know that acrylic restorations have more breakage, wear, and staining than zirconia. So we as providers have an opportunity to minimize that by selecting the correct prosthetic material. And lastly, material bulk. How thick is the restoration? And in that, I mean, we need to control the seam. In just a moment, we will get into controlling the seam, but that seam placement determines how much bulk of material we have. peri-implant mucositis and peri-implantitis. How are we going to minimize that over time? Well, the World Workshop told us to make sure that, or guided us that implant distribution, specifically proximity, has an effect on these biologic conditions. If the implants are too close, the patient may not be able to clean in between them. And when the implants are too close, the bone between them may be at risk for deterioration. Once again, prosthetic material has an effect on peri-implant mucositis and peri-implantitis. How so? Well, studies have been done looking at the ability of these different materials to harbor pathologic biofilm. And it's been proven that acrylic harbors more pathologic biofilm than zirconia. And then lastly, prosthetic design, the restorative tissue interface and how it interacts with the tissue is going to affect the biologic complications over time. So again, we need to control the seam. In summary, because I mentioned it several times, talking about acrylic versus zirconia, we can look at whether or not acrylic or zirconia is the better option in fabricating these prosthetics. So when we talk about breakage, zirconia has less breakage. Talking about wear, zirconia has less wear. Staining, zirconia has less staining. And then the biologic conditions, the zirconia has less biologic complications over time. Glidewell's own Jack Hahn was quoted as saying, acrylic hybrid dentures all have a common problem. They eventually break. So I had mentioned controlling the seam. What exactly is the seam? The seam is the long horizontal tissue restorative junction, the inter-implant prosthetic space of the FP3 partial or full arch restoration. Let's look at it a little closer up. Let's define some areas. This is a cross section through the lip and the prosthetic and the alveolus. So we have the lip, we have the tooth prosthetic material, the gingival prosthetic material, the alveolus, and the connection between the prosthetic gingiva and the tissue is referred to as the seam. The seam is surgically controlled. It's surgically controlled at the time of implant placement in the form of ridge reduction. And ridge reduction is necessary for strength of the prosthesis, the aesthetics of the prosthesis, and the health of the prosthesis. And let's look at each one of these individually. When we talk about strength in the seam, ridge reduction for interocclusal prosthetic space provides a bulk of material for strength. If there's not enough bulk for strength, the prosthesis is at risk for breakage. So what is that minimum space? Well, if one were to measure from the tissue to the central groove or the tissue to the cingulum, an acrylic FP3 restoration needs a minimum space anywhere from 15 to 20 millimeters. And monolithic zirconia needs less, between 12 to 15 millimeters. Next, aesthetics. We're going to talk about aesthetics and the seam. But before we do, let's just give a little basic review on the aesthetics and the smile line. In a relaxed state, the lip is going to cover the tooth and potentially only show a small portion of the incisal edge. But as one smiles, the dynamic movement of the lip, the display is going to change. And we can categorize the display as a low smile line. So at the maximum dynamic extent of the smile, only the tooth is exposed. The average smile line, so again, with the maximum dynamic extent of the smile, the interproximal tissue and maybe a small amount of the gingival margin is exposed. And then in a high smile line, with the maximum dynamic extent of the lip, you're going to see the tooth, you're going to see the interproximal tissue, and you're going to see a band of tissue, gingiva. So how does that come into play and how does that affect the FP3 restoration? Well, the aesthetics of the FP3 restoration are in large part determined by the seam. and you have to be able to hide the seam for success. So in our the example that's on the screen right now, this is a low smile patient. At the maximum dynamic extent of the smile, the seam is hidden in their success. In this other image, which is a lady that has a high smile line, at the maximum extent of her smile, you can see the seam. This is an aesthetic failure. She's very upset, and she's been posting on one of these Facebook support groups looking for advice on how to manage this problem. It's not easy. So how do we determine where the seam needs to be? Well, in a low lip line patient, the extent of ridge reduction is determined by the minimum requirement for interocclusal bulk for strength. We just looked at that. We looked at those dimensions. So in this example, low lip line smile, the ridge reduction is done. We have adequate bulk for strength, and the seam is hidden by the lip. Aesthetic success. In a high lip line patient, the extent of ridge reduction is determined by the requirement for interocclusal bulk and strength and the need for lip line aesthetics. So let's look at our example, high lip line patient. Surgery is done, implants are placed, ridge reduction. And in this first example, there's enough bulk for strength, but the seam is visible. This is like that lady that I just showed you. This is an aesthetic failure. So what do we need to do? We need to reduce more ridge. So not only is the strength demands met, but the aesthetic demands met of hiding the seam as well. Let's look how the seam has an impact on health of the FP3 restoration. Inadequate ridge reduction, which I just showed you, will lead to an aesthetic failure, which then requires the restoring dentist to ridge lap the prosthesis to hide the seam. Let's look at that. Here's our high lip line patient. Strength bulk is met, but the aesthetics are a failure. You can see the seam. So what the restorative dentist may choose to do is to lap the facial of the prosthesis to basically position that seam more apical underneath the lip. So in this case, strength is met, the aesthetic criteria is met, but the health criteria is not. A fixed ridge lap prosthesis is not cleansable. There's no water picking or flossing in the world that is going to get into the concavity of this restoration. So I'm going to make the point, a ridge lap or modified ridge lap in an FP3 restoration must be avoided at all times. I'm going to make the point again, a ridge lap prosthesis must be avoided at all times. So again, we're controlling the seam in the FP3 restoration. Proper ridge reduction, in summary, and seam placement is the key to strength, aesthetics, and health in the FP3 restoration. Ridge reduction is what we're talking about. Zircc in 2021, a recent paper on this technique, is commented as stating bone reduction is not arbitrary and should be planned. Well, how do you plan it? Well, we need a guide. We need to know exactly where to position that seam. This can be done analog or it can be digital. Let's look at two cases, one of each. This is a patient that has periodontal disease. He's going to lose all of his teeth, and he was treatment planned for an FP3 restoration. So in the analog world, the teeth that are going to be provided immediately the day the implants are placed, those teeth begin as what we call a conversion denture. It's just a regular denture that has been fabricated the way a regular denture would be fabricated, in that the tooth position is optimized, the lip support is optimized. And then once that conversion denture is fabricated, it's duplicated. And when it's duplicated, the seam is prescribed in this surgical guide. That seam is positioned to maximize strength and aesthetics. And so now that you have that seam in a surgical guide, the bone can be reduced in accordance with that seam. This is how you get the bone in the right position. Now notice that the bone has been reduced to a greater extent than where the prosthetic seam is positioned. It's because tissue has dimension. After this surgery is completed, the tissue will be covering that bone. And so remember, the seam is measured from the tissue to the central groove or cingulum. So we need to account for that tissue dimension in bone reduction. And this is the patient finished up with a Zirconia FP3. Let's look at a digital example. Again, this lady is going to lose all of her teeth due to periodontal disease and has been treatment planned for an FP3 full arch restoration. And in the digital workflow, her existing teeth are digitized. Her planned reconstruction is digitized in her smile. And from that, implants can be planned. And most importantly, the bone reduction level can be planned. This is a kind of a view of how much bone reduction is needed for strength and aesthetics and health. And so in the midst of surgery, this is a stackable guide workflow. The base guide itself becomes the guide for where to remove bone to. So again, this is not arbitrary bone reduction. This is all planned ahead of time. This is the interim PMMA restoration on this case. So up till now, we've been really just talking about corrective maintenance. You know, things that are potentially going to happen to the FP3 restoration and what we can do as providers, surgeons and restoring dentists to minimize their occurrence. But once the restoration has been delivered and the patient leaves the office, from then on, it's all about preventive maintenance. Again, this is proactive. Things that can be done to prevent a problem before it has occurred. In my office, when I provide these restorations, everybody receives a night guard, especially if the restoration is going to be acrylic. Parafunctional nighttime grinding will wear out the acrylic restorations, so they receive a night guard. Food is a weapon. Back at my days at Penn, Lenny Abrams, one of my professors, would always walk around talking about food as a weapon. Food is abrasive. Food has density. And depending upon what we do with our teeth to eat is potentially going to affect the longevity of the restoration. And so specifically with acrylic restorations, the advice to my patients is be careful what you eat. Now, you know, they've just got this great appliance and they maybe came from a place where they had removable appliances or periodontal disease, and they're really looking forward to having a good meal. And I would never want to take that away from anybody. They just need to be aware that the foods they eat are going to cause maintenance issues of that prosthesis over time. Our patients need to clean the seam. We spend a lot of time talking about the seam. They got to clean it because the seam is the entryway to the abutments. This is where the biologic complications occur. If they can't clean the seam, they can't clean the abutments. They can't clean the abutments. And remember, peri-implant mucositis is biofilm mediated and the precursor to peri-implantitis. They got to be able to clean the abutments. In addition, they need to be able to clean the tissue surface of the restoration. The inter-implant pontic site, the seam, is fairly long. And if it's not cleaned, it will ulcerate and become inflamed. not a healthy situation. Preventative maintenance, what we do in the office and how often we do it is important. We'll get into that specifically here in a minute. And then lastly, what do our patients need to do at home? And they can come into the office 2 times a year, 4 times a year, but that still leaves 360 days at home that they have to do what they have to do. The seam presents a challenge to preventive maintenance. There's no doubt. The location of the seam is 3-dimensional, and its location and position affect the ability of our patients to keep it clean. Let's look at some different aspects of that location. The location vertically, this is measured from the edge of the lip to the seam. The further that seam is underneath the lip, the harder it is to clean. There's a horizontal component to it, and that's measured as the distance from the facial surface of the tooth to the seam. And that distance varies. It may vary because of the need for lip support of the prosthesis. It varies due to the potential buccal alveolar atrophy that has occurred because of surgery and a prior periodontal disease. In any event, there's a difference between the horizontal differences, and the less horizontal difference there is, the easier it is to clean. There's an angulation component to the seam, depending upon how our surgical colleagues perform their ridge reduction. And this can be measured relative to the occlusal plane. The flatter the seam is, the easier it is to clean, the easier it is to get something into it. The more acute the seam is, the harder it is. And then lastly, tissue contact of the seam, which really is the amount of free space between the tissue and the restorative tissue surface. It can be open, much like the old hygienic conics of 3-tooth bridges, or there can be tissue contact and compression. And in the maxillary arch, there's always tissue contact and compression. Otherwise, our patients will lisp and spit bubbles through the seam. But the lower arch doesn't have that same requirement. So maybe, and I'm just proposing, the lower arch cases should be open. It's easier to keep clean. So now we get into the in-office maintenance protocol. And in 2016, the American College of Prosthodontics, prosthodontists, delivered a position statement on what we should do for in-office maintenance, as it provides a guideline to the clinician on what to do when they come in for their routine visits. And it can be separated into different time points, starting with the day of delivery. On the day of delivery, number 1, first and foremost, the restoring dentist needs to confirm cleansability. So what I do is I reach into my drawer and I get one of those blue loop threaders. If I can't get that through the seam, now remember, in an all-on-4 patient, there's 3 areas that you need to be able to get something into the seam. The more implants, the more areas that need to be cleaned. If I can't get that blue threader into the seam, there's no way our patients are going to be able to do it at home. So modifications may need to be made. Maybe a little less tissue compression. Maybe you need to remove the minor facial ridge lap that we have asked our laboratories to build into the restoration. But you need to confirm the cleansability. We take probing depths. Probing an FP3 restoration is almost impossible. You can't get to the sulcus of the abutment underneath the seam. But if you can get to 1 site per implant, that's good to measure for comparison over time. Radiographs. You must take radiographs on the date of insertion. This becomes the best tool that we have for being able to evaluate the health of the implants over time. The interval appointments. What do you do when the patient comes in for their routine cleaning? And how often should we see them? Well, first, frequency. There's no defined interval. It's based on individual risk factors. For example, history of periodontal disease. Remember the World Workshop where they said that that was a risk factor for peri-implantitis? If our patient had periodontal disease, which means that they're at risk for peri-implantitis. Maybe they need to be seen a little bit more often. Systemic conditions, diabetes, dexterity, their limited vision, whatever it may be, we may need to see them more often than every 6 months. At every maintenance appointment, of course, we review medical history, comprehensive evaluation of soft tissue. We're looking at, for redness, signs of mucositis, swelling, bleeding on probing, suppuration. We look for a change in probing depths. And again, it may only be one site per implant, but that may be the best that we can do. And then we have to ensure that they can perform oral self-care. Their ability to adequately clean that seam at home is paramount. Again, we may see them twice a year, but that's still 363 days that they got to do what they got to do at home. If they can't do it, then we may need to see them a little bit more often. Radiographs. The recommendation in the position statement is every 1 to 2 years. I take x-rays on my implants every year. It's equivalent to a bite wing x-ray. It's equivalent to a bite wing x-ray for diagnosis and treatment. So I take x-rays every year, but the ACP recommends every 1 to 2 years. And you take a radiograph anytime that there's infection. Removal. Do we need to remove the FP3 restoration at every maintenance appointment? No. That is not the current recommendation. When do we remove them? When there's signs of peri-implantitis. We remove them so that we can fully evaluate it and treat it. Remove the restoration. If there's a demonstrated inability to maintain oral hygiene, we may need to remove this restoration for cleaning. When there's mechanical complications that require repair, or if the prosthesis is loose, we take it out. And when we do take it out, the recommendation is to replace it with new screws. These screws wear out over time. The last thing you want is a prosthesis where you can't get it out because the screw head is stripped or it has broken. Let's go back to some of these early studies, the Swedish group and the Toronto group, because this is not new. This is not new information on maintenance. The Swedish group, Brandemark and Adele and Leckholm, they are quoted as stating that great care was taken to design their bridges with sufficient peri-abutment spaces for oral hygiene. They knew it was important. And in Brandemark's 1985 book, he actually illustrated a picture of what they give their patients to keep clean at home. Superfloss, gingival stimulators, and a toothbrush. They knew that it was important. The Toronto study, again, it was a little bit more difficult for the patients to clean due to the FP3 nature of it, the seam that was developed, but they counseled each patient about tissue and prosthetic care. And what they recommended was water picking, superfloss, toothbrushing, and Proxibrush toothbrushes. Back in 1990, that was the protocol for at-home maintenance. So what does the ACP, that position statement, say about at-home maintenance? Well, they say that we must be able to provide adequate oral hygiene to ensure successful maintenance. Well, what is adequate oral hygiene and what tools do we have for it at home? Well, the tools that we have available today are toothbrushes, obviously, toothpastes, water picks, water flossers, interdental brushes and picks, and then floss. And of course, not regular floss because you can't slide this through the contact of teeth, but specific floss, threader floss. And then of course, there's something new that helps with this, the AutoFlosser. Let's look at each of these individually. Toothbrushes. I kind of came across an article that was done in 2019 looking at electric toothbrushes and manual toothbrushes and the full arch implant restoration. And no surprise, they found that electric toothbrushes resulted in better plaque removal than manual toothbrushes into the seam. What was also interesting is that they were kind of concluded that whether it was an electric or a manual brush, both were ineffective at removing plaque in the palatal areas. No surprise if you're brushing from the facial into the seam. Toothpastes. My patients always ask me what toothpaste to use. Well, the problem with these FP3 restorations is that they're not teeth, they're prosthetics. So I recommend a product. It's Dr. B's, that's the brand name, Cleanadent paste. And the reason I recommend it is because it's the only paste that has the ADA seal for dental prosthetics and mouth tissue. And the reason why I recommend it, in addition to the approval, is that it's ultra low abrasive. Because remember, the acrylic restorations, they're going to wear. We talked a lot about attrition in food, but you can wear these prosthetics with a highly abrasive paste, with a toothpaste. So I recommend this product for cleaning the FP3 restoration. Water flossers. Most patients that have an FP3 have either been recommended or somehow been recommended to clean their teeth with water flossers. So let's look at what the literature states about that. For teeth, there's no doubt, and it's been confirmed, that water flossers will reduce gingival inflammation. That has been confirmed in the studies. But what many of the authors do state in the studies is that it does not have a beneficial effect in reducing plaque. Remember that biofilm that causes peri-implant mucositis. Interestingly enough, the depth of penetration of these water flossers is only half the depth of the pocket. It's only getting halfway down. But what's most interesting about water flossers is that the action relies on compression and decompression of the tissue, the pulsation of the water. When a constant stream of water was used to clean teeth, that was not effective, or not as effective as this compression decompression. So when it comes to the FP3 restorations, first of all, there's lacking any real study at the effectiveness of water flossers. But I question whether or not that water jet, the pulsating water jet, can compress and decompress the peri-abutment tissue. If that's the mechanism of action, I don't know whether or not that's happening around the abutments of these FP3 restorations. However, the water flossers are very good at rinsing out food debris and other debris in the seam between the abutments. Interdental brushes, another tool that we have for teeth, quoted as these are the most effective method for interproximal plaque removal when you can get them into the gingival embrasure of a tooth. Well, first of all, there's no studies on FP3 restorations, but the problem is that they require open embrasures. And I made the point that in the maxilla, the seam is not open. It needs to be closed. Otherwise, there's lisping and bubble blowing. If there were open embrasures, or if the seam was open, these would probably be very good tools to clean the abutment space and the tissue surface of the restoration. Lastly, floss. This particular study in 2021 used floss as a control versus other types of cleaning aids, especially in the office, without having to remove the prosthesis. And the result was, to no surprise, that sponge floss was highly effective in removing plaque from the abutments and the prosthesis. The problem with flossing, the FP3, is that you have to get the floss into the seam. And depending upon the different factors that I had mentioned, like the vertical location, the horizontal location, the angulation, it affects the ability for our patients to be able to do so. So what we have available today are those blue floss threaders, highly cumbersome. I don't know how anybody can use them, where they actually have to put a strand of floss into the loop and then bring it through a space. And then came along super floss. We call this leader floss. That's the generic name, where you have a pre-cut strand of floss that has a stiff end to it attached to a spongy section. And then what makes it even easier beyond that is the AutoFlosser. Let's look at the AutoFlosser a little bit more in detail. It's a novel device that aids in passing floss under anything connected or joined. So not only the FP3, but 3-tooth bridges, orthodontics, bonded retainers. The reason it works so well is it allows easy positioning and angulation into the seam. The tip can get up underneath the lip, no matter how far underneath the lip it is, into that horizontal distance, and then position at the right angulation to get through the seam. Once the tip is positioned at the seam with the simple turn of a wheel, it pushes the floss through to the other side. It is great for those with dexterity, arthritis, neuropathies, coordination problems, large hands, small mouth, etc. In addition to the AutoFlosser has a modification called the AutoFlosser Notch and Groove. It's a slight modification made to the tissue surface that may help those prosthetics that have slight ridge lap or firm tissue compression. So if you're developing or delivering an FP3, and on the day that you're inserting it, you take out your blue threader and you just can't get it through. Maybe there's a slight ridge lap that you asked for. Maybe there's a lot of tissue compression. Well, with this modification, it actually allows cleansability of that prosthesis. The notch helps to orient the tip, and the groove helps the floss pass through to the other side. Here's the AutoFlosser in action. The tip is brought to the seam. It's inserted in the seam. With the turn of a wheel, the floss is pushed through to the other side. You hold it, you pull it, you lock it, and then you can use the AutoFlosser as a guide to move the floss back and forth, C-shaped floss around the abutments, and remove the biofilm. So in summary, just kind of make a couple of points. The FP3 implant restoration is unique, and it has its own unique maintenance requirements. To minimize maintenance over time, to minimize that corrective maintenance over time, consider Bruxer over acrylic. Plan your ridge reduction to control the seam for strength, aesthetics, and health. And lastly, at-home maintenance needs to be individually prescribed, and it's likely going to require multiple tools to remove all of the stains, food particles, and biofilm. And with that, I want to thank everybody for their attention, and certainly available to answer any questions.
Hey, thank you, Tom. And I just have to say that I've been in this field for 30 years, and that is the best lecture I've ever heard on maintenance of these types of restorations. That was, I really never heard anybody link up the maintenance problems with the treatment planning from the beginning. And I just think you did that beautifully. Thank you. Thank you very, very much. Yeah. Our extremely sophisticated audience has a bunch of questions for you. And yeah, right. I know we're late, but let's keep going as long as we can. Okay, you talked a lot about the importance of this. You called it a seam. I always called it the transition line, you know, between the restoration and the tissue. And it's very important to get under there to clean those abutments. Now, as you said, because of these aesthetic issues, sometimes people ridge lap to hide the transition line. There's also a method of using neurotoxins to lower the lip line. What is your thought about that?
Yeah, so like Botox and other botulism toxins have been proposed to help people with the aesthetics of the gummy smile. So it's been used a lot in just aesthetic dentistry. On that same note, if one was left with a visible seam, could that be a solution to an aesthetic problem? Yeah, potentially, for sure. And anything that we can do to hide the seam yet make it cleansable is a win for the patient.
Okay. And I mean, there are certain times when you just can't do adequate ridge reduction, right? There's you know, if you did enough ridge reduction to hide the seam, you wouldn't have enough bone height to place an implant.
Then the patient may not be a candidate for an FP3. I mean, in all honesty, or I mean,
and that would be maybe an overdenture would be a good treatment.
Like an overdenture, a snap-in denture, some of these more complicated precision bar type restorations, spark erosion bar type restorations. But if you go through the planning like I did digitally, which really helps because you can see how much bone you're going to have. If you're not going to have enough bone to place dental implants and hide the seam at the same time, then they're not a candidate. They're not a candidate because the alternative is you have to ridge lap it. And once you ridge lap it, you've lost any ability, and depends upon the extent of the ridge lap, but you've lost any ability to really keep it clean.
Okay, so this is something you need to know before you start the case, right?
Right.
So how do you make that determination, right? The patient, let's say the patient's coming in with a terminal dentition, right? Like the cases you showed. How do I know where my transition line is going to be, and how does that line up with the remaining bone and the lip line?
So with cone beam technology and digital technology, it's kind of easy, but here's what you need to know. You need to know, number one, where the planned incisal edge of the restoration is going to be. And you need to know, number two, in a dynamic movement, how high does that lip move away from the planned incisal edge? That's baseline information. That's baseline information. Now, once you have that dimension, most implant planning today is done digitally. You can take that planned incisal edge position, and you can then on your planning software know where the seam needs to be. And then at that point is where you start making the fixture levels of your implants.
Very good. Very good.
In a vertical dimension, yeah.
So you mentioned this AutoFlosser device, which you designed that device, right?
I did.
I did.
And I designed it specifically for this problem. Yeah.
Yeah, I mean, we tried it out at our clinic. Dr. Manley used it on some of our full arch cases. You know, the best maintenance device is the device that the patient will actually use, right? And we had very good experience with this AutoFlosser device. If anybody that's on the webinar wants to get one, how do they find out more about this?
So there's a couple of ways. Number one, there's a website, theautoflosser.com. And you know, because of your invitation, I'm happy to extend a promotional code, GW20. Get a 20% discount off of one or more units. But if you're looking for more information, I'm very open to emailing. You can email me at info@theautoflosser.com. If you wanted to talk about volume discounts, if you wanted to talk about functionality, if you wanted to talk about, you know, anything related to the lecture, I'm happy to field those questions.
Great, great. All right, couple more questions. If the patient you know, has perio problems and is not so good at maintenance, do you still go on with the fixed restoration? You know, Dr. Hochberg and I, this is something we always talk about, is that these patients are lousy at maintenance. That's why they're losing their teeth, you know. And if you only do implant cases on people with wonderful maintenance, you're not going to get to do too many implant cases.
Right.
How do you draw the line there?
Well, you know, I think with everything related to dentistry in general, it's all about, you know, proper planning and setting levels of expectation. So the conversation that needs to happen with these patients doesn't occur with the closure of the last screw access hole on the date of delivery. That's not when this conversation starts. It starts from the very beginning. They need to understand and they need to be educated, and you would be surprised on how many people this is new information, right? You would think, we all think that you know, like we're born knowing that plaque causes disease. It's not the case. We have to educate our patients. And quite honestly, if there's a patient that says, you know what, I'm not going to do that. I'm not going to clean this in the way that you're recommending. And that may be a patient that that won't do it. But I have to tell you that that's pretty rarely the case. You know,
I've also seen that people, once they spend $30,000 to treat that arch, they suddenly become a little more interested in maintaining it.
That and having suffered with ill-fitting removable prosthetics, you know, just wanting to be able to eat a meal, they're ready and willing to do what it takes to have something that's fixed in place like this.
Great, great. Okay, a couple more questions about the acrylic versus zirconia. You mentioned that you provide a night guard for patients with acrylic restorations because of the high wear factor. Do you provide a night guard for patients with zirconia full arches?
I do, for no other reason than I'm a creature of habit. Potentially there's some joint beneficial effect. But in addition, depending upon the occlusal setup, there's still stresses that are going to occur with the canine rise and the anterior disclusion, that if the patient is in parafunction, it's going to work on those screws and it's going to work on the junction. So everybody gets a night guard.
Okay. And here's a question we get all the time, and there's no literature. I mean, we've done 85,000 zirconia arches here. And so we feel like if there was a problem, we would know about it. But do you have any thoughts as to implant failure rates for acrylic restorations versus zirconia restorations?
It's exactly the same. The studies that are out right now, and obviously there's longer studies for acrylic and prosthetics than zirconia, but that's not the trend. That doesn't seem to be the case.
Very good. Tom, again, excellent lecture. We're getting a ton of really gracious comments from our attendees. We really appreciate it. Such great information, and thank you so much. Thanks to our panel for their contributions as always, and thanks to all of you for joining us on this Good Friday. We wish you a wonderful Easter and Passover holiday, and we'll look forward to seeing you back next week when we will have, as always, our business advisory panel, and our guest speaker will be Dr. Steve Barrett. He'll be coming back for part 2 of his series on predictable aesthetic outcomes. So let's meet back here next week, and everybody have a wonderful week and take care. Bye-bye.
Thank you so much, everyone. Appreciate it.